Okay, fine. Okay, so I was given quite a broad remit for the talk today about women's health, and the topics were far and wide. I tried to narrow down a little bit because I wasn't sure how much everyone's background understanding was before, and it can be sometimes a bit information overload to cover all of gynae. So I have focused on periods, fibroids, endometriosis, and PCOS, which are some of the more common topics. Probably not enough time for fertility, cancer, other things, which should you wish, we can do another session if you want. Okay, so we'll get going. Okay, so first it's really important when people are telling me about periods is to understand what is normal. So most periods for most women can vary anyway. Anything between about 21 and 35 days is normal. Classically, in the textbook, they always say it's a 28-day cycle, but if you have a 25-day cycle or a 32-day cycle, that is normal too. A lot of women say their periods are either very heavy or very painful, and I've got to say those are quite subjective measurements, and I'll go on in the next few slides to talk about causes for heavy or painful periods. And in general, periods should usually be regular, so like one period per month approximately. This is kind of like a little bit of a refresh of basic anatomy. So you've got your womb, the lining of the womb that sheds every month, ovaries, fallopian tubes, and the cervix of the surface. So the causes for heavy periods. So most of the time when people come with heavy periods, the most common cause is actually just hormonal. So no cause is found. It is just called dysfunctional uterine bleeding is the medical name, or heavy menstrual bleeding. That is by far the most common cause that we see in practice, probably about 90% of cases, but it is a bit of a diagnosis of exclusion. So the first thing that we normally talk about is how heavy are the periods? So in the textbooks, they say that you can, if you were to measure all the blood from your period for the cycle, it would equal to about 80 mils, and that's about average. And so heavy menstrual bleeding is bleeding more than that. I have never seen anyone weigh their pads, but a good way to gauge if your periods are particularly heavy, if you find that you are changing your pads every hour or 2 hours during your period, that is pretty heavy. If you're passing clots, particularly more than like a 10p size, I would describe that as quite heavy. And if you are flooding, i.e. you're bleeding through your sanitary pad or tampon onto your clothes or your bed linens, I would call that quite heavy too. So normally when people come with a diagnosis, it's usually a bit of a diagnosis of exclusion just to make sure we're not missing anything else before we confirm that it's just hormonal changes. Other things that can sometimes cause abnormal or heavy bleeding, sometimes infections in the lining of the womb, sometimes polyps, which are just like skin tags, either on the lining of the womb or on the cervix. Sometimes you can have genetic disorders which cause your body to not clot, so you just bleed much more than normal. But for these women, usually they bruise very easily, and they would have had probably known problem from the get-go, from the first time they started having periods. Really rarely to get cancer causing heavy menstrual bleeding. We'll talk about this a little bit later, but generally speaking, particularly in the young demographic, who are the ones which tend to have heavy periods, endometrial cancer is not usually the most, it's quite a rare cause to explain it. And fibroids we'll come on to a little bit later. So the treatment, if anyone has heavy menstrual bleeding, the treatment depends a little bit on the cause from the last slide. Most patients, when they go to see their GP, they usually prescribe 2 different drugs to help with the bleeding. The first is something called tranexamic acid, and this basically helps your body to clot. It acts on the clotting system, so it minimizes bleeding. And often when women have very heavy periods and they start passing a lot of clots, it's very common for the womb to start cramping quite a lot. And so usually heavy and painful periods often tend to go hand in hand. And non-steroidals tend to be more effective than, say, paracetamol to help with painful periods. The most common one that we prescribe is mefenamic acid, but if it's not possible to get hold of that, then things like Nurofen would also work. The other kind of mainline treatment that we offer for heavy periods, which has kind of revolutionized the treatment of it over the last 20 years, is the Mirena coil. And it's basically a small hormone containing progesterone only coil that sits in the womb cavity and slowly releases the hormone. It can stay in for 3 to 5 years. It can be tricky to put in when you're awake, but it is well tolerated. And it's very easy to take out. But because it's slowly releasing the hormones only to the lining of the womb, it does mean that that it can take a while to have a proper effect. Because if you can imagine, you're not taking a huge dose as a tablet. So to have the effect, it tends to be local and takes about 3 to 6 months before you usually see any benefit. It's incredibly effective at keeping the womb lining healthy. In fact, it's so effective that we can sometimes use it as treatment for early stage womb cancer. It's got a very protective factor for the lining of the womb. I put down this just as a separate side. So you'll hear the word coil, and there are basically two groups of coil. One are the hormone coils, like the Mirena, and the other is the copper coil. So the copper coil tends to make bleeding much heavier and just generally makes the pattern and the heaviness much worse, and the hormone ones tend to make it much better. Other things that you could try if the bleeding's very heavy is other forms of contraceptives. So the long-acting reversible contraceptives, we call them, things like the depot injection, or an implant that goes just underneath the arm, the crease of the arm. And they basically also are different versions of progesterone hormone in quite high dose, and they make the lining of the womb very thin, often by stopping ovulation. The other two things to touch on is sometimes a polyp, like a little skin tag, is in the lining of the womb, and that can make the bleeding much heavier, and that can be removed through a simple surgical procedure. And sometimes fibroids, which we'll go on to next, can make the bleeding much heavier. I put down ablation here mainly just in case anyone ends up undergoing this. So if you can imagine that the womb lining can sometimes is the one that's shedding, causing the bleeding, and some people don't want any hormonal treatment at all. They find it just doesn't really work well with them. If your family is complete, then sometimes we offer this procedure called an ablation, where we put a little device like a wand inside the cavity of the womb when you're asleep, and we open it up and it stretches up to a fan, and it burns the lining of the womb. And by burning the lining of the womb, it reduces the heaviness of the bleeding. The main thing for that is that you can't have children afterwards, because it causes a lot of scarring in the cavity of the womb. So if the family's complete and someone doesn't want and has heavy bleeding, doesn't want any more children, then the ablation is usually an option. A lot of the things like the coil and ablation tend to need a relatively normal looking womb. So some people can have fibroids. So fibroids are basically extra lumps of muscle in the womb. They can be different sizes. They can be in different locations. So sometimes they're in the inside lining of the womb. We call them submucosal. Sometimes they're in the muscly bit of the womb, called intramural, and sometimes they're on the surface of the womb. We call them subserosal, so just on the surface. Depending where the fibers are, and depending on the size, will impact the symptoms people have. And we usually treat them only on the basis of symptoms, because they're incredibly common. So studies have shown that about 40% of women over the age of 40 have fibroids. So they're ultra common, and we see them routinely when we do scans. They are typically diagnosed on an ultrasound scan. So this is just a picture of the lining of the womb. That's the inside lining, and that little ball-like structure there, that's the fibroid. Generally speaking, if they're on the inside lining of the womb, what we call submucosal, they increase the surface area of the cavity, and that can cause much heavier bleeding. If their fibroids are huge, like 10, 15, 20 centimeters, then they can cause pressure symptoms, which makes sense because the womb is floating around inside the tummy, and the bladder's in front of it and the bowels are behind it. And if the womb gets very big, you can get constipated. It can cause pressure on the bladder and cause someone to feel like they need to wee. So sometimes it causes pressure symptoms, and sometimes when the fibroids are very big, it can get painful too. The way to confirm the diagnosis is an ultrasound in the first line. Very occasionally we use an MRI scan if we're not really sure of the location. And treatment for the fibroid very much depends on, as I said, the size and the type, and the symptoms. So if bleeding is the big issue, then we discuss the Mirena coil. The coil is usually our first line. And you can put it in even if there are quite a few fibroids. Sometimes it's less effective. Sometimes it's more difficult to put in. But if the patient is willing to try, it's usually a good first line tool. Other options would be the contraceptive pill. So people used to say that you need to bleed every month on the combined pill, but actually you can put the combined pill have like 3 cycles back to back, and then bleeds, take your pill break at the end of 3 months, and then repeat it to try and minimize the number of periods you have per year. And that's a safe approach. Sometimes when the fibroids are inside the lining of the womb, so when we put the little the camera inside and the fibroid is bulging out, you can almost nibble at the fibroid to smooth it down. We call that TCRF, transcervical resection of the fibroid, and that's done usually as a day case. But it very much depends on the position of the fibroid, because you can imagine if you had a large fibroid on the outside, putting a small camera on the inside just not going to get to it. Pressure symptoms are a bit more tricky, because for pressure symptoms, usually the fibroids are quite large. Usually things like the hysteroscopic resection, like the TCRF, doesn't really seem to do the trick. I'm not sure what that beep was for. So for pressure symptoms, the best option, which is the most definitive, is surgery to either remove the fibroids, we call them a myomectomy, or to even offer a hysterectomy. Kind of as a rule of thumb, most hospital in the NHS would recommend a hysterectomy after the age of 40 rather than a myomectomy. The reason for the age difference is that hysterectomy is actually an easier procedure and safer than a myomectomy, removal of the fibroids. And so the only reason ever to remove the fibroids but not the womb is if women still wanted to have children. And because fertility rates are quite linked to age, most units would recommend a myomectomy for people still wanting to conceive and have a good chance of conceiving, so under 40. And as you approach kind of 40, certainly by 45, most units will not be offering a myomectomy, just because it's a much harder and more risky surgery, and they would only offer a hysterectomy. There are some alternatives to having surgery. There's a procedure called uterine artery embolization, which has gathered momentum over the last maybe 10, 15 years. And it's done as a day case by the radiology department, where they basically they use a big vessel either in the wrist or in the groin, and they inject these tiny like little gelatinous balls, and they use a image guidance to help push those gelatinous balls all the way to the uterine vessels and the blood supply to the uterus. And as those little balls kind of sit there, they reduce the blood supply to the womb, and the fibroids can shrink. Uterine artery embolization is only suitable for certain types of fibroids, and it's quite at the discretion of the radiologist who's doing it. So not everyone with fibroids would be suitable for that procedure. And when the procedure was first designed and the license for it was granted, they have said that if you want to have children, it's a contraindication. So you shouldn't really be performing uterine artery embolization if for women who wish to have further children. The other two options, sometimes you can ultrasound scan, like an MRI focused ultrasound scan. I don't know any unit in the UK that actually does that, but that apparently does exist as a modality. And the last one is a special type of injection of a high dose hormone that switches off the ovaries and puts you into the temporary menopause. We call it a GnRH agonist. And it's quite useful for women who were thinking about surgery, but I've kind of got so fed up, their bleeding's been so heavy, they become really anemic, and they just want kind of a temporary but quick fix. And so you can give this injection like Zoladex every month for 3 or 4 months. It helps shrink the womb, shrink the fibroids, stop the bleeding, and it can give women at least a few months respite. Because it effectively causes a temporary menopause, it's not something we really use in the long term, particularly for younger women. We kind of use it as a bit of a stopgap, either if women are waiting for surgery or if they need a few months respite. I wrote down the other option people used to use a drug called Esmia, which got introduced maybe about 5 years ago, but then they had a lot of instances of liver failure. So it's being withdrawn off the market about 2 or 3 years ago. But that used to be something that we used to give. And then possibly the last thing just to touch on is fertility. So fibroids being ultra common, and that we tend to treat only the symptoms of the fibroid, be it bleeding, pain, or pressure. Whether the fibroids have caused infertility or have made it more difficult for women to get pregnant, and whether treating those fibroids will make a difference, has always been a bit of a contentious issue over the last 10-15 years. There is definitely a lot of evidence that women with multiple large fibroids, particularly fibroids in the cavity of the womb, have higher infertility rates. And we think that may be because sometimes the fibroids can kink the tubes, and so they can block the tubes, causing fertility problems. And sometimes the presence of the fibroid can affect the endometrial lining and affect some of the little small delicate receptors on the lining of the womb, or affect the hormonal geographical bubble around the fibroid and in the lining of the womb, and that can make it more difficult for women to get pregnant. So current recommendation does very much depend on multiple factors: how long the patient's been trying for a baby, if there are any other causes for fertility, how big are the fibroids, where are the fibroids. I think fibroids which are within the lining of the womb, I think it's very reasonable to offer treatment, because I think there is a lot of evidence that they will help improve fertility rates. Fibroids which are causing the womb to be very large and stretched, like 5 to 10 or 15 centimeters, even if they're not in the lining of the womb, there may be a benefit. Potentially the smaller ones, probably the risk is more about with removing them rather than keeping them. But it's a bit of a contentious issue, to be honest, and I think the research is still evolving. So the next topic to touch on, which is really common and we see it all the time in clinic, is painful periods. So most of the time women have painful periods. It's actually just part of normal physiology. A lot of women can have painful periods, and as we discussed in the last section about bleeding, the most common things we give are paracetamol and non-steroidals. Non-steroidals tend to be more effective, and particularly mefenamic acid. Sometimes bath, gentle exercise helps too. If the periods are heavy, we can give this clotting drug called tranexamic acid. And sometimes contraceptives which can stop periods, like the progesterone-only pill or the combined pill or the Marinacol, can help with painful periods too. Sometimes the painful periods are due to other causes. So the two that we tend to see in practice is endometriosis and adenomyosis. Both are pretty common. So if this is the womb and the lining of the womb, you've got your tubes and your ovaries on each side. Normally the endometrium, the lining of them, should just really just be confined to the lining of the womb. It shouldn't really be anywhere else. So if the lining of the womb makes its way a little bit deeper into the muscle of the womb, we call that adenomyosis. And the problem with that is, if you can imagine that every time you have a period, you bleed from the lining of the womb, you also bleed in those little pockets in the muscle, and blood itself can be quite an irritant to muscle. And so bleeding into the muscle of the womb can cause really severe and crampy tummy pain. The diagnosis for adenomyosis is actually quite difficult. So whilst we sometimes see it on an ultrasound scan, it can be missed quite easily, and MRIs are sometimes performed to look at the womb. Sometimes we do a camera test where we put a camera into the lining of the womb called a hysteroscopy and take some biopsies, and the biopsy can confirm the diagnosis. But I've got to say, a lot of the time, the diagnosis remains missed until the women have had enough of the pain and have a hysterectomy, and then the final pathology from the hysterectomy shows adenomyosis. It's not a dangerous condition, but it can be a big factor for pain. And it is more common after the age of about 40 to 50. Young women don't tend to have adenomyosis. The other common cause for pain is a condition called endometriosis. So this is where the lining of the womb doesn't stay in the lining of the womb, but instead of making its way to the muscle, it migrates to rare places. It can make its way to the ovary. It can make its way to the fallopian tube. It can go onto the top of the bowel. it can attach to the bowel or the bladder, it can attach even under the diaphragm of the underneath the lungs. So it can migrate its way to places far and wide. And in the same way that every cycle that the womb lining bleeds, all those little endometrial deposits of lining everywhere else will also bleed with the endometriosis, which means if there's a little deposit on the ovary, every time you have a cycle, that little deposit will also bleed. Or if it's on the bowel, every time a period starts, it can also cause bleeding from that site too. So it does mean that the clinical manifestation can be quite vast depending where those little pockets of endometriosis end up. It tends to cause cyclical pain, so pain kind of worse around the time of the period. It can also cause pain on intercourse. It can cause, if it's stuck to the bowel, it can cause pain on defecation, going to open the bowels. If it sticks on the bladder, it can cause pain on the bladder when people pee. Sometimes it can cause bleeding from the back passage or from the bladder with the cycle. It's relatively common. About 10% of women have it, and the most interesting thing really with the condition is that the degree of endometriosis we see doesn't always reflect the symptoms. So someone with quite severe disease don't seem to have any symptoms, and some people with very mild disease have quite severe symptoms. And so because of that kind of the gap, often the diagnosis for endometriosis is made quite late, and studies have shown that often the diagnosis is made about 8 to 10 years after women have been complaining of symptoms. With the endometriosis within the ovary, we call those chocolate cysts because the blood gets collected within the ovary, and each time there's a cycle, it bleeds that little bit more. So the ovary cyst gets bigger and bigger and bigger with blood. And because the blood is old, it gets like this brown color. So we call them chocolate cysts. So if you ever hear the term chocolate cyst for endometriosis, that's what they're talking about. The investigations and treatment. Ultrasound tends to be one of the first line investigations we do for most of gynecology. Sometimes when there's a lot of things that look like it might be stuck on the ultrasound scan, then an MRI can be useful to help plan surgery, but it's not routine. And then the gold standard is a laparoscopy, which is an operation where a small camera is inserted into the belly button, and the tummy is puffed up with gas, with CO2, and a camera is inserted, and we have a look at the inside of the tummy to see if there's any evidence of these like little deposits that are associated with endometriosis. The laparoscopy is kind of like the gold standard way. So ultrasound doesn't always pick up small deposits because the lining of the tummy, we call the peritoneum, is quite fine, and you can't see always deposits on the scan, even amongst experienced operators. So laparoscopy really, unless you've had that, you can never really exclude endometriosis. With the laparoscopy, you can also offer treatment. So you can have a look to see if there are little deposits, and if deposits are seen, then you can remove them. If this is laparoscopy of someone with severe endometriosis, so this is the womb and the tube and the lining of the womb, the peritoneum, and this is one of the ovaries, which is grown large, so you can see it's almost the size of the womb, and inside it is that chocolate cyst, the cyst filled with blood from the endometriosis. This bit all the way here should usually be relatively mobile, and it looks a bit stuck, but these aren't images, these are all images from Google. On the right images, you can also see kind of like a pictorial diagram. So this is the womb, the bladder, and the rectum. So this is a cross section of the tummy kind of going directly through the middle. And the endometriosis deposits can go anywhere. So they can stick from the womb to the bladder, they can stick on top of the womb, between the bowel and the womb. And that can make surgery quite difficult. So normally the doctor who sees someone with endometriosis will talk them through the risks of having removal, because all these deposits can be removed, but depending on the site of it can make the operation quite difficult. And so, for example, if there's a big lump of endometriosis on the bladder, you can remove it, but there is a much higher chance of causing a bladder injury and having to have a catheter or tube in the bladder for 10 days for the recovery. And similarly, if there's a big lump of endometriosis on the bowel, you can remove it, but there's a higher incidence of bowel injuries and needing a stoma. So those discussions are probably the most important thing you should ever do before you undergo surgery. So you can decide kind of the level of treatment that you want and the risk you're willing to take. In terms of other treatments for endometriosis, it doesn't cause cancer, so you can actually do nothing if you're happy with the pain. Painkillers, physiotherapy, TENS machines, psychological support are already useful. And effectively, you want, in terms of drugs, anything that will stop ovulation, because when you stop ovulation, you stop the cyclical bleeding and you stop bleeding from all those other peripheral sites. And lots of different hormonal contraceptives can cause that. For example, the contraceptive pill, the progesterone-only pills, the Mirena coil tends to be the most popular choice. But even the depot injection or the implant can sometimes help the bleeding too. Kind of as a last line, we give the same drug that I was talking to you about earlier called the GnRH agonist. And that's the injection to put the ovaries into a temporary menopause. And that will also stop people ovulating and bleeding for a few months to give them a bit of respite. You'll notice from all of these options, all of them are contraceptive. So for women who are trying for a baby, it can be a little bit more difficult. So the next slide, I'll come back to that. So the women with endometriosis can struggle more than the general population to conceive. And I wanted to put down kind of like normal statistics first so people can have an idea. So if one considers 100 women 100 couples all trying for a baby and having regular sex for a year, over the course of the year, 84 will get pregnant. So that's kind of like defines effectively normal fertility. For women with mild endometriosis, 75 will get pregnant a year. Moderate endometriosis, 50, and severe endometriosis, 25. And so for women with quite severe endometriosis, where there's endometriosis maybe on the bladder or the bowel or large endometriomas, a discussion for surgery is not unreasonable. Particularly for large endometriomas, they tend to have much worse outcome. And certainly referral to IVF would be indicated if they struggle after a year. There are some famous faces who have endometriosis. You'll probably recognize some of these. So Whoopi Goldberg is one of them. She's a famous writer, but she's been very vocal about her endometriosis journey as well. And Amy Schumer and Alexa Chung. So they've got some quite good celebrities who are endorsing the endometriosis support groups. Depending on the fertility advice, therefore, surgery is often indicated for larger endometriomas. For endometriosis on elsewhere, it's more usually for symptom control. Okay, let's move this. Okay, so the other topic I want to touch on is for periods. So we talked about heavy periods, we talked about painful periods. What about really spaced out periods? So the medical name we give that is called oligomenorrhea. And for women who have no periods, we call that amenorrhea. So I know it's probably a bit of information overload, but this is a hormones. I wanted to show you kind of like the hormonal pathway that causes people to have periods, because it's important to understand some of the conditions that follow. So a lot of the signals originate in the brain in an area called the hypothalamus, and they feed signals to another part of the area of the brain called the pituitary. They act on the ovaries through another set of hormones, and based on that, the ovaries will respond with the two kind of biggest female hormones, estrogen and progesterone. And there's a little feedback cycle to make sure the balance is just right. Depending on when the periods start to not work, there's an imbalance somewhere within this pathway. So on the side, you can see if there's a problem with the hypothalamus, it can stop working. If there's a problem with the pituitary, which is quite rare, but usually it's rare conditions like prolactinomas where people get, they're not pregnant, but they start producing breast milk is usually the telltale sign. PCOS, which we'll go on to next. Sometimes if the womb has got a lot of scar tissue, we call that Asherman syndrome, it can be very difficult to get pregnant. Probably the most common cause of no periods whatsoever is actually pregnancy. I'll touch on two things I see quite often in clinic. Or one is things people are worried about. So women who have had no periods for about a year and do a pregnancy test and it's not pregnant, and they get really worried and stressed and get referred to clinic. Most of them are referred for worried about premature ovarian failure, where their periods stop really, really early. Most women have the menopause at the age of 52, 53. With premature ovarian failure, we define it as like less than 45. Certainly 40 is a bit of a red flag. The way you make the diagnosis is very simple. It's a blood test. And what happens in early menopause is that the ovaries deplete all their eggs. And so in an effort to try and force the remaining ovaries to try and push to produce more and more eggs, your signals go to the brain on this little feedback cycle to increase the levels of all the hormones ahead of it. And so your pituitary starts churning out really, really high levels of FSH and LH to force the ovaries to produce whatever eggs are remaining. And so the test for premature ovarian failure is actually very simple. You do a blood test to look for these two things. And if the LH and FSH are really, really high, it's a sign for premature ovarian failure. Having said that, for most women I see in clinic, that's never the reason. That's only really a handful of women. By far the most common reason for no periods is hypothalamic dysfunction, which is basically, if you imagine there's this area in the brain, there's a bit of an imbalance, and it causes everything downstream of it not to function quite so well. And it's a really difficult thing to tease apart because the reasons that cause that hypothalamic are actually quite subtle. It's usually women are stressed, and because stress can interfere with that signaling process on the with the hormones or the GnRH. It can be over-exercise. We see a lot of athletes, their periods stop completely. It can be women who are depressed or have had sudden weight loss or sudden weight gain, or if they've been really poorly with an illness. And so it's quite difficult to have that discussion with some women who may be training for like a triathlon and their periods have stopped, but they want to have a child. And although they consider themselves very healthy, their body is telling them something else, that maybe they need to cut back a little bit and let their hormone levels reset to a normal rhythm. And so if the treatment for hypothalamic disorder is essentially to normalize whatever of these causes are. And sometimes we can use the pill in a temporary measure to try and get them back into a cycle. One of the common causes we see for spaced out periods is PCOS. So PCOS doesn't usually cause no periods at all ever after, but it can cause periods to reduce in frequency. So rather than having once a month, you might end up having it 2 or 3 times a year. So we don't entirely understand the reasons for polycystic ovarian syndrome. We know for sure it's an imbalance in the hormone signaling pathway. So if I go back, there's another set of hormones here, which are the androgens, which are like the male hormones. And in PCOS, the hormonal balance is a little bit shifted, and the male hormones, the androgen levels, start to build up. And the androgen hormones can switch off this axis and makes the period stop. Let me just move this out of the way. So effectively what ends up happening is usually every time, for every cycle, each ovary, one of the ovaries, will produce loads of little follicles, like 10 to 15 little follicles average. And the best follicle with the egg inside it will eventually burst, the egg will be released, and it will go down the fallopian tube waiting for conception, waiting to produce a baby. In PCOS, because of the hormonal imbalance and the change in the androgens, the male hormone, what ends up happening is all the little eggs get stimulated to grow as normal, but none of them ever quite make maturation. So the egg never actually gets released. All the little follicles remain, but it doesn't reach that last step where the egg is released. So what ends up happening is if you were to scan the ovaries, you get this appearance. So this is an ovary on transvaginal ultrasound. You get loads of little follicles, like 15, 20, 30 little follicles. All looks very healthy, but that is one of the telltale signs of ovary, and it's one of the criteria for diagnosis. The other criteria, as I said, is to do with androgen. So androgen is kind of the male hormone, and often it can result in more acne. It can affect weight, and it can affect hair growth, so particularly kind of around the face, so like male pattern. And the third one, which we mentioned, is irregular periods. So really, for the definition for PCOS, it's 2 of these 3 symptoms will give you the diagnosis. The one thing just to mention, so polycystic ovarian syndrome is not actually ovarian cysts, because it's kind of a misnomer with the name. It's a common misconception. So you can see on the ovary, these are like little follicles. Cysts by definition have to be quite a certain size, like at least 3 or 4 centimeters. And the cysts on the tiny little follicles on the scan with PCOS are more like at 5 millimeters, a centimeter. They're very small. And so although they call it polycystic ovarian syndrome, it's actually not, they're not really officially true cysts. They give this a very classic appearance. It is also very common. About 10% of women have PCOS, and a lot of women who have it don't know they have it. The importance of polycystic ovarian syndrome is threefold, really. First, because it's affected the hormonal pathway, it's been linked strongly to something called diabetes and insulin resistance. And insulin resistance and PCOS tend to go hand in hand. So insulin is a hormone produced by the body in response to high levels of sugar to help reduce the sugar in the body and to control it. And for some women, they're not able to control their sugar levels very well, and so your body produces more and more insulin in response to this to try and get it to normalize the levels better. So you get this concept called insulin resistance, and that's linked to high cholesterol as well. So one of the main things for PCOS to keep an eye on is diabetes. So GP should really be checking for diabetes, not necessarily every year, but every few years, in conjunction with a good diet to make sure people don't develop that. The second thing, which is still quite rare, particularly in young women, is endometrial cancer. So normally the lining of the womb should shed the lining of the womb about 3 times per year. I think anything less than that, the lining of the womb builds and the cells can start to become abnormal and thicken. We call that hyperplasia. And so really, if women have got PCOS and they're not having 3 periods a year, then we normally recommend even the progesterone-only pill or the contraceptive pill just to force the lining of the womb to shed once or twice extra during the course of the year. And the third one that is makes PCOS particularly important is for fertility, because if you can imagine on the last diagram, that each time you're meant to ovulate, all the little follicles get start to grow, but none of them quite ovulate, so you don't get the ovulation. So if you're not ovulating properly, natural conception is impossible. So a lot of women seek help for fertility reasons, and the treatment really for PCOS, probably the mainstay for treatment, is to try and reset the hormonal axis and try and normalize people's hormonal axis effectively. The easiest way to do that for those women who are obese, weight loss is by far the best tool that you can use. It's better than any drug that we use. It's better than surgery. Weight loss is the most thing, but not all women with PCOS are overweight. So for women who've got a normal BMI and normal weight loss, obviously you don't need to go further than that, but there are other things we can try. There's some drug called metformin, which is basically an insulin sensitizer. Inositol, which is basically an over-the-counter supplement, has been shown to help as well. Low GI diets, folic acid to reduce inflammation, vitamin D and omega-3, all of them have been shown to help in and are safe, but the effect, I've got to say, is not dramatic. They're quite mild benefits. For women who are hoping to conceive, the 2 biggest avenues people use is a drug called clomiphene. It's an ovulation induction drug. We normally give it for women in the beginning of their cycle, and it kind of forces the ovaries to kind of churn out the eggs to ovulate. You can't really use it for more than 3 to 6 months because it increases the risk of ovarian cancer. So it's really only licensed for short spells. So normally for women, we give that as a first line, try and help them get pregnant. The other option is a daycare surgery called ovarian drilling, which is a bit of a bizarre concept, but for women with PCOS, if they do a surgery, so this is laparoscopy and that's the womb and this is the ovary, if you burn the surface of the womb 20, 30 times with a surgical device, it tends to reset the hormonal balance produced, the estrogen, progesterone, testosterone levels released by the ovary undergo a bit of dynamic change as a result of that, and that sometimes reverts to the changes of PCOS. We call that ovarian drilling, so that's commonly performed. In terms of other treatments, if it's not for fertility, and there's women have normal weights, and it's just maybe for hair growth. There are some drugs we can give to help with hair growth. Some of the contraceptive pills have a anti-testosterone or anti-androgen component, which make them better at helping with PCOS. And a good example is Dianet. The reason it's kind of not given to every woman is all pills increase the risk of blood clots, and some of the pills, like this one, make the increase of blood clot risk much higher. So we don't tend to give it for women unless they've got an extra reason to have it. And the last reason we mentioned already for endometrial cancer, it's important to have at least 3 periods per year. And so either you can achieve that with having the coil-in, or forcing it with a pill, or progesterone like norethisterone, just to force 3 bleeds per year. So the last topic, I think this is the last one, was what happens in terms of regularity. So we've talked about heavy bleeding, painful bleeding, spaced out bleeding, or no periods. What happens if you bleed too much? You're getting extra bleeds. So extra bleeds is never normal, but it doesn't always mean there's anything bad. It's important to always get investigated, mainly just to exclude all the serious stuff. But for most of the women we look after, it's nothing. It's fine. It's usually just due to hormones. The things that are important to exclude is infections, because sometimes infections like PID, pelvic inflammatory disease, can cause weird bleeding patterns from the lining of the women, weird discharge. That's a really simple test. You can just do swabs. It's important to make sure women are up to date with their smears and make sure the cervix is healthy. Sometimes polyps or abnormal cervix can cause abnormal bleeding. And it's important to have a scan to check the lining of the wound. There aren't any polyps or fibroids in the way, which can cause extra bleeding. And polyps, we said, were like little skin tags, which are easily removed. Very, very rarely can cancer cause intermenstrual bleeding, but you would see that on the scan. There would be some abnormal features, and then the doctor would normally take a biopsy in clinic with a little device that looks like a straw. I think everyone here looks like they're young, but just to mention, if you know anyone who has bleeding after the menopause, you should always get checked out. So GPs are advised to refer anyone with bleeding after the menopause on an urgent care pathway for cancer. So they should get seen within 2 weeks by healthcare professionals. Most of the time, 90% of the time, it's nothing nasty. It's just either a polyp or just the low levels in hormones in the body causing atrophy, making the tissue thin, easy to bleed. But in 10% of the cases, it's cancer. So referring anyone with even one bleed after the menopause is essential and good practice. Any more information on these topics? For Instagram, these are 2 doctors who do quite good blogs on gynae-related stuff. The Gynae Geek used to be my SHO many years ago. I think she's a registrar now. Websites, RCG's, like our governing body, has quite a lot of information leaflets, and Endometriosis UK is quite a large support group that provides a lot of useful information. I think that might be it. Yes. Okay. So I'm going to stop the screen sharing and you can ask anything you like.
Right. Thank you so much, Dr.